my fellow doctors. Welcome to today's live discussion on a truly critical and exciting topic breast cancer surgery. And we will be exploring the innovations in oncoplastic techniques. I'm Hetvisha, and I'm so thrilled to be your host for today's live discussion. But before we dive in, I want to remind all of you to leave your questions in the comments, and we'll be taking them after the session or during the session. So please do not hesitate to ask anything that's on your mind. And today we are incredibly fortunate to have with us one of the leading minds in surgical oncology, Dr. Vipin Goel. Dr. Goel isn't just the clinical director and head of surgical oncology department at Star Hospitals in Hyderabad, but he's also a pioneer who has redefined the standards of surgical care. Over the past 13 years, his innovative approach, particularly with the Goel's technique for laparoscopic hysterectomy, has gained international acclaim. And among his many accolades, he's been recognized as the most pioneering oncologist in India for 2024 by the Times Network, a testament to his impact in the field. So, Dr. Goel, welcome, and we are so honored to have you here today.
Thanks, Hatvi, for your introduction. Thanks for your kind words.
Thank you. So now, without further ado, doctor, let's just jump right in. So, if doctor, you have developed some groundbreaking techniques over the years, such as the Goyal's technique. So, how has your surgical approach evolved, especially in breast cancer surgery, to combine with precision center, to combine precision with patient-centered care?
In oncology, the first point what we keep in mind is always when we are treating the patient is cure. Nothing else should override the cure. But over the years, what we have achieved is cure rate has improved because of systemic treatment or other things. But in addition to cure, can we increase the quality of life of the patient, increase the psychology, decrease the depression? Because as if we compare the surgery, what I used to do 30 years before, it was mastectomy, where we used to remove complete breast. Now, with evolution, we know the breast cancer is systemic disease to start with, and we can increase the cure rate by introduction of chemotherapy, target therapy, and multimodality treatment. Here, what we have come up with breast preservative conservative surgery, where there is no need to remove complete breast. We can remove only the lump with margin and give the same cure. We have evolved from mastectomy to breast conserving surgery, and with respect to axilla, where we remove the lymph node to assess where the disease has spread to the axilla or not. Before we used to do axillary clearance, where we used to remove complete lymph node. Now we have moved from axillary clearance to sentinel node, where first we remove the only draining 2 or 3 lymph node, and if they are negative for malignancy, we don't remove complete lymph node. The advantage is there is a very low chances of lymphedema, restricted arm movements, and pain. We have evolved from radical surgeries to less radical surgery. Before the concept was more is better. Now the concept is less is more. We do less and give better.
Yes, I think that is so truly said that less is more, and it is very true when we speak about cancer care. So now my next question would be something that I think you would be facing every day. So when a patient actually walks into a clinic with a breast cancer diagnosis, what are your thought process in deciding between breast conserving surgery and mastectomy?
Yeah, good question. So whenever patient walks to me, first what we do is we do metastatic workup, where we see what is the stage of the patient. To tell you in short, it is divided into three: T N M. T stands for tumor size, N stands for nodal status, and M stands for distant metastasis. Metastasis is there, we don't operate. So that is out of question. Now comes to the, we see various parameters. What is the T state? What is the N state? T state is what is the tumor size? We see with respect to patient, with respect to disease, and with respect to biology of the cancer. With respect to stage, we see what is the tumor size, whether the tumor size is appropriate for BCS or not. Example, if the tumor size is more than 5 centimeter, it is a relative contraindication. Second, if the nodes are positive, means this is an aggressive disease. Then we see the patient factors. What is the breast size? Whether the breast size is big or small. Because a small tumor in small breast may be not ideal case for BCS. Whereas a small tumor in big breast is an ideal case. Or a big tumor in any breast is a relative contraindication. So what I see is what is the biology of the disease, whether it is an aggressive tumor or not, what is the tumor size, what is the breast size, what is the psychology of the patient, whether patient is keen for BCS or for her safety is more important. Then I rule out few of the contraindication for BCS, like all patient of BCS should go for radiation. If the patient is there is some contraindication for radiation, then I don't offer BCS. Presence of multiple tumors in the breast is a contraindication for breast conservative surgery. Pregnancy is a contraindication. So we see the biology, tumor size, whether patient can take radiation or not, whether the patient is keen for breast preservation or not. We explain all this to the patient and take everything in consideration and take a call.
So different factors also play a role, and I think
Yeah.
even comorbidities would come into picture if the patient is facing anything, any else.
Comorbidities, here comes what reconstruction we are deciding. If we only go for oncoplasty, which is a breast displacement, we divide breast reconstruction broadly into two categories. One is displacement, one is replacement. Displacement means we take the surrounding tissue of the breast and reconstruct. It will not increase the morbidity, but yes, you are absolutely correct. If we are going for some major operation like free flap, tram flap, where we take tissue from some other part of the body like abdomen and reconstruction, then what you told is absolutely correct. The morbidity required is high, and if patient is high risk for surgery, we want to finish in short. We don't offer them free flaps.
Yes, that is true. Now, I'll ask my next question would be that once you have mapped out a surgical plan for a cancer patient, how do you navigate the delicate conversation around the timing of breast reconstruction? And what are your approach when discussing immediate versus delayed reconstruction with patients? I think that would be a very complex discussion
Correct,
sometimes.
correct. So the reconstruction in breast is usually divided into two categories broadly. One is early reconstruction, one is delayed reconstruction. What is the difference? If we are doing the reconstruction of the breast during the same time when we do the resection, when we remove the breast and same time we do the reconstruction, it is called early reconstruction. Whereas delayed reconstruction is we do oncosurgery, we remove the tumor, give chemotherapy, radiation, whatever required, and after some time, if you do the reconstruction, usually 6 months or 1 year later, it is called delayed reconstruction. There are advantage and disadvantage of the both. Let me just enumerate the advantages of early reconstruction. Most important, single surgery. So no need for two anesthesia, cost effective because the two surgeries will increase the cost. One surgery we do, the cost will be less. Then second, the psychological impact on the patient will be less because they have not seen their body to be mutilated for 1 year. That will create a wrong psychology on the patient mind. It may create a problem. So the reconstruction we do, they will see their body as normal and it will have a low psychology on the patient. But the advantage of delayed reconstruction is we know the biology of the disease. What we mean by biology means what are the chances of cancer coming back. If in that 1 year the chances of cancer coming back is very high, then we tell wait, let us see the biology of the disease, and if the cancer does not come back, we will do the reconstruction. But usually nowadays, I'm offering all the patient early reconstruction because of the advantages what I have enumerated.
Yes, I think that also has a lot of advantages, so it is better.
Yeah,
And strategic plan is also necessary sometimes.
correct. And the delayed reconstruction usually is a little bit difficult because once we are given radiation to the chest wall, there is some fibrosis. So delay reconstruction can be a problem, but early reconstruction, the tissue is naive. It is not because of radiation. There is less of fibrosis. So cosmetic result will be better.
Yes, that is very true. Now, let's talk about the neoadjuvant therapy that is going on. So, how has this pre-surgical treatment reshaped your approach and the outcomes for your patients?
Yeah. What we mean by neoadjuvant treatment is if we give any systemic treatment like chemotherapy, immunotherapy, targeted therapy, or hormonal treatment before the surgery, it is called neoadjuvant treatment. The advantage of neoadjuvant treatment is most important is downstaging the disease. As I told you, the staging of this in TNM. T stand for tumor, N stand for nodes. If we feel the tumor size is very big, 8 centimeter or 10 centimeter, where surgery is not possible, where we call it as inoperable tumor, by giving chemotherapy with down stages, at 8 centimeter will become 4 centimeter or 3 centimeter. That time surgery becomes very easy. So most important indication is to downgrade the tumor, make a inoperable cancer operable. Second, some patient, because of the big tumor size or small breast, upfront BCS will not be possible. I cannot do breast conservative surgery upfront. That time, what I give chemotherapy, I reduce the size of the tumor, and then I remove the tumor. To convert a inoperable BCS to an operable BCS, I give chemotherapy. Third, the advantage of neoadjuvant chemotherapy is I can assess the response of chemotherapy in situ. When I'm giving the chemotherapy, I can see whether a tumor is shrinking or not. If it is shrinking, that means my chemotherapy is working. So I can assess the response to the chemotherapy in the body only. And sometimes there can be macrometastasis. As we know, the breast cancer is a systemic disease, so we give chemotherapy to kill the macrometastasis which has spread all over the body and increase the survival. So neoadjuvant chemotherapy in nutshell is given for downgrading the tumor, increase the cure chance by killing the macrometastasis, make inoperable operable, and to assess the response of chemotherapy in the body.
Yes, that is so insightful. Now, in the realm of personalized care and especially considering cancer and breast cancer, genetic factors like BRCA mutations play a big role. So, how do these factors influence your surgical decisions, and how do you guide your patients through these complex choices?
Good question. BRCA testing is now very important for almost all the breast patient, and thanks to Angela Jolie, little bit awareness has been created all over the world about the BRCA gene. To the people, to crowd who don't know about BRCA gene, this is a gene involved in causing the breast cancer and hereditary breast cancer. Means if mother is having BRCA mutation, there is a very high chance daughter will have this gene and may develop a breast cancer. Knowing BRCA gene is important with respect to the patient whom I am treating and also to the family. I will divide into two. First, to the treating patient. For treating patient, if the patient is BRCA positive, then there is a high chance of recurrence because it is a hereditary genetic mutation which is caused. So I'll be a little bit reluctant to offer breast conservative surgery to the patient because if there is a high chance of recurrence, if I do BCS, patient may develop one more cancer in the same breast. Second, I will offer prophylactic surgery for this patient. What do we mean by prophylactic surgery? It is also called preventive surgery, where I remove the organ before a patient develops a cancer. Like if patient develops cancer in the right breast and I do BRCA gene testing and it comes positive, then I will offer them to remove the opposite breast also. And if they are okay, they have completed their family, to remove the ovaries and fallopian tube also. Because the BRCA mutation patient develop ovarian cancer and fallopian tube cancer and ovarian cancer. So I will tell them preventive surgery, you can remove the opposite normal breast also and ovary also to prevent cancer. Now, with respect to family, I will tell all the children of the patient who are BRCA positive should do this gene analysis. And if the gene is positive, then either they can go for screening through mammogram or MRI, or if they have completed their family, then they can go for prophylactic surgery if they also have BRCA gene mutated.
Yeah, I think this must also be the most challenging decisions that you should one healthcare professionals has to take.
Yeah, but all this has to be done in collaboration after counseling the patient and family about the advantage and disadvantage.
Definitely, yes. Now, speaking of the challenges, let's just talk about how complex is managing breast cancer cases, and can you share how your approach to these cases and the role of multidisciplinary team plays in ensuring the best outcomes?
Yeah, good question again. About the multiple disciplinary team, just to highlight the place where I'm working in Star Hospital, Hyderabad, I have a team of 11 doctors where we meet every Tuesday to discuss the difficult cases, whether patient should undergo surgery first, chemo first, or radiation first. Because breast is not a single disease. Breast cancer is a heterogeneous disease where we can subclassify into almost many subtypes where the treatment for each subtype is different. So all breast cancer is not same. What we do is we bring that case on table and discuss whether this patient will benefit from surgery first or chemo first. Then we take a call. Many times what happens is where the multidisciplinary team is not there, a patient goes to a surgeon first, he will operate first, or go to a medical oncologist, he will give chemo first. But the practice which we have started and we strictly follow is a difficult case. We present through the tumor board where each clinician will bring his expertise on table to discuss what is best for the patient, keeping everything uh, keeping everything out. What is best for this patient? Example, I am being a surgeon, surgical oncologist. My expertise is less in chemotherapy or medical oncology or radiation oncology with respect to my colleague who is giving chemotherapy. Similarly, my expertise in radiation is less as compared to my colleague who is giving radiation every day. So, what we do, we sit together, bring cases, discuss what is best for this patient, and we take a call. If I feel surgery is better, my colleague feels chemotherapy is better, we discuss what are the advantages and disadvantages. It has to be a healthy discussion, keeping your ego aside, keeping patient in the center, and think what is best for the patient. To give you
Absolutely, I
one
think that is.
example, to give you one example, one patient came to me with lump in the breast and lymph node throughout the abdomen. Then we went to the discuss board and tumor board and discussed. We thought this is not the pattern where the breast cancer will spread. Maybe it is something different case. So we did biopsy after the conclusion, after the tumor board discussion, and that lymph node from the abdomen came as TB. So patient was having cancer of the breast with TB of the abdomen. But outside where they have shown, they told it is stage 4 and they told patient is going to die. Nothing can be done. But we thought because of tumor board, maybe something else we are discussing because here 11 minds are coming into the picture. One mind sometimes may not think anything. So first thing you should fix is in your mind is you don't know everything. You should be open to learn. 11 mind comes, somebody will think outside of the box and tell this may be something else. We did biopsy for that patient, he came as TB. Now we treated the TB, we treated for the breast cancer. Breast cancer also cured, TB also cured. But outside they were told it is stage 4, nothing can be done. This is the advantage of multidisciplinary team.
Actually, that was a very good approach that you practice at your hospital, and especially considering the complications that cancer can give. Like just like you mentioned, the case, it was incredible. Now, shifting a bit of our focus, what are the most common complications that you encounter post surgery, and what proactive strategies do you see to mitigate these risks?
Yeah. Compared to the other surgery of the abdomen, like cancer of the pancreas, colon, or stomach, usually the risk for breast cancer surgery is less. It is not very major surgery as compared to the carcinoma, lung, pancreas, stomach, or colon. This is some of the cases where the surgical complications are low. The incidence is low. But yes, if we see the incidence, it is 2 to 8%. In this, the most common complication will be infection, bleeding, and wound complications. Infection, as this being a skin surgery, there can be infection of the skin leading to pus formation and discharge. Second complication can be wound healing. Sometimes if the patient is obese or there is a comorbidity as diabetic or infection is there, there can be gaping of the wound and wound may completely open up. Or there can be necrosis of the skin where the skin will become black. Then, being a lot of raw area, there is a chances there can be bleeding and hematoma formation where there can be bleeding from the wound and lead to fall in hemoglobin and fall in RBCs. Because of the lymph node dissection, as I told you from the starting, there can be swelling of the hand, what we call as lymphedema, and there can be seroma formation. The fluid, what is there, which will be draining through the drain, what we put, if it collects inside the wound, it can form a seroma. To mitigate all these things, we have to follow strict antiseptic or aseptic precaution where we have to give a dose of antibiotic on table before surgery, clean the wound properly. Post-operative, take care of the wound properly. We put a drain to drain the dead space, what is left behind after removing the surgery, and don't remove the drain early. Keep it till it becomes 20 ml, 30 ml for 2 consecutive days. And to prevent the lymphedema, we have come with newer techniques, what we call a sentinel lymph node biopsy, where we remove only 2 nodes and send. If it is negative, we don't do the axillary clearance. Following meticulous surgical steps is the most important thing to prevent all these complications. If we follow all these steps properly, the complication rate can be kept as low as 2%.
That was very crucial, and I think prevention care is also crucial. Everybody should take some prevention care. Now, finally, before we go ahead with audience questions, one last question would be, Doctor, you have been a trailblazer in integrating oncoplastic surgery techniques. So, how have these innovations improved outcomes for your patients, both in terms of cancer control and cosmetic results?
Yeah. As I told you from the starting, most important in cancer is cure. Nothing else should override the cure. With this all these oncoplastic techniques, we have not improved the cure rate, but it is as same as mastectomy what we used to do. So cure rate remains the same, and that is the most important thing. If I give good quality of life, good cosmesis, good aesthetic appearance, everything, but the recurrence rate is high, cure rate is low, I should not offer that. So BCS oncoplastic technique, everything is giving the same cure rate as any radical surgeries, but there are many advantages. Most important, patient, for them it is a self confidence is very important. If they see their body, it's a scar, every day they see the scar, that will keep on reminding them I have a breast cancer patient. But if it give a good cosmetic results, after some time they will forget it. After 5 years also, if patient is not having recurrence but they see the scar on their chest wall, it will remind them of the trauma they underwent 5 years ago. I am a breast cancer survivor. But with these oncoplastic techniques, the trauma is less. It is improving the quality of life, giving self-confidence to the patient. They can go back to the society and family and have their self-esteem and self-confidence. They can live a normal life without that, without having the trauma of I am a breast cancer survivor.
Yes, that is actually very true. And especially we are seeing cases in younger women with breast cancer. So
Yeah,
this is really helpful for such women.
correct.
And thank you so much for sharing your insights. And
Yeah, my pleasure.
now let's just take a few questions from our engaged audience. So the first question that we have is, what future innovations might improve the oncoplastic surgery?
Future innovation will be with respect to the microvascular reconstructions where we take a flap from some other part of the body like abdomen, thigh, and anastomose the vessel of the donor part to the recipient part by microvascular reconstruction. The advantage is the loss is more also. I can get lot of tissue from the abdomen. With the innovation of the microvascular reconstruction, we can give very good cosmesis for the as big as bilateral loss of the breast. Just to show you one picture, where I have done. Let me. Hathvi, you want to see the,
Yes, of course.
yeah, to this with respect to this question about the
Yes,
innovation what we have done. Let me share a photo.
that would be wonderful.
Yeah, just let me share. You can see this picture.
Yes, yes, we can
Yeah.
see.
You can see the picture clearly.
Yes, we can see it clearly.
Yeah. So see what's happening here is this is the patient where patient underwent multiple lumpectomies. You can see this scar, one here, one here. This is the patient where the patient was BRCA positive. So what we have done is we have done removal of both the breast, but the tissue defect was big. So what we have done, we have taken a tissue from the abdomen and done reconstruction of the breast. See this scar? With this scar, I have removed the breast on both the side, and with the flap from the abdomen, we have done reconstruction of the breast. Same case, if I have not done the reconstruction, picture will look like this. See the flat breast, both the side. So this is the
Yes.
difference. This without reconstruction and this picture with reconstruction. This is the advantage what we are giving to the patient. This is the another example where we have taken this incision, did mastectomy, taken a flap from the thigh and done reconstruction of the breast.
Okay, that is something very innovative and nice, and I think that is very useful also for the oncoplastic technique.
Yeah,
Now, one more question, doctor, we have is I think this is a very good question. When deciding between breast conserving surgery and mastectomy, how do you incorporate the latest imaging modalities such as MRI or PET and CT into your decision making process?
yeah, good question. So for this, you should know what are the contraindication for breast conservative surgery. As I told you, multicentricity means presence of more than one tumor in different quadrant of the breast is a contraindication. So my imaging modality helps me to diagnose whether the patient is having single tumor or multiple tumors. What all this imaging do is they tell me कि patient is having only one tumor in one location or multiple tumor, and I will decide based on that whether this patient is fit for breast conservative surgery or not.
That was also a really good response. Now, one more question that is there is how do you manage the surgical decision making process for BRCA mutation carriers who are considering prophylactic mastectomy but are also interested in preserving their fertility?
Good question. This is a very good question.
Yes.
So what we do is, if somebody is BRCA positive, actually there are two options. If somebody want to preserve the fertility, then what we do is we tell them you can go for regular screening. What do you mean by screening? We can diagnose the cancer early. The whole purpose of treatment in cancer is to give cure to the patient to increase the survival. One option is surgery, prevention, where we remove the organ so that cancer will not develop only. Second option is we do regular screening to detect the cancer early. For this example, BRCA gene, what we do is we can do transvaginal ultrasound to see if the patient is developing any lesion in the ovary, and also do a tumor marker called CA125. The whole purpose is screening to detect the cancer in pre-malignant condition or stage 1, where the cure chances are more than 95%. For breast also, if somebody is not keen for breast mastectomy, if they are BRCA positive also, we can do regular mammogram or MRI of the breast to detect the cancer early. This is also a recommended option. To summarize, two options. One, you can go for prophylactic surgery or you can go for regular screening to detect the cancer early.
Yeah, I think early detection also plays a major role, and everyone should look out for early symptoms, I think.
The purpose of screening is to detect the cancer before one develops symptoms. So if somebody develops symptoms and come to me, it is not called as screening. Patient, we should detect the cancer in somebody before the symptom develops. It is called screening. The whole purpose is we should detect the cancer and treat the cancer before one develops symptoms.
Makes sense, yes. How do you approach cases where there is a high risk of recurrence post surgery, and what protocols do you have in place for monitoring and managing these patients?
Yeah. If the patient is high risk for cancer or low risk for recurrence, does not matter. We follow standard protocol what is recommended for the breast cancer patient who underwent complete treatment. Every 3 months, we call the patient for regular examination. We take detailed history if any symptoms are there or not. We do breast examination to detect if any lesion is there. We examine the axilla and the supraclavicular region to see the any recurrence of the nodes are there. Then every year we have to advise mammogram for this patient. And based on symptoms, we can do either PET scan, CT scan, or MRI. But PET CT MRI is not recommended for all the patients. The only thing what is recommended for breast patient is every 3 month examination by the doctor and every year mammogram. Any other test you want to do has to be symptoms related. Example, if patient tells back pain is there, then I can do bone scan. If patient tells abdominal pain is there, I can do ultrasound abdomen. But usually what happens, they come and ask me PET scan, I want to get it done. But it is not for all. Recommended is every 3 month examination and yearly mammogram is enough.
Right. One more question we just got is, Doctor, what are your views on Keynote 522 trial approach of triple negative breast cancers?
Triple negative breast cancer are usually very aggressive tumor. For such cancers, usually we give neoadjuvant chemotherapy, irrespective of nodes are involved or not. Because as I told you, this breast cancer is not a single disease. It is classified as many subtypes. And triple negative is one of the very aggressive breast cancer, where they will not have local recurrence more. They can have distant recurrence more. So I have to tackle that first. So all my triple negative breast cancer for very selected patient where the tumor size is like 1 centimeter or 2 centimeter, I may offer surgery. Otherwise, all these patients will go for chemotherapy first, followed by surgery.
Yes, I think the same doctor is asking one more question is, how does oncoplastic surgery impact radiation therapy planning?
It will not impact because the what we have planning radiation where we have to cover the supraclavicular region if nodes are positive, axilla and the complete chest wall. So chest wall will not decrease. If you do mastectomy or BCS, your chest wall will not decrease. But if the biology is very less, we may reduce the radiation doses little bit. But the area what we are giving radiation is not going to change.
Right.
Sometimes we may cover the internal mammary lymph node also, provided the disease are more, but the area is not going to decrease the much. Those may reduce for early diseases and low risk. Like before, we used to give radiation for almost 5 weeks. Now, with low biology, low recurrence rate cancer, we finish the treatment in 3 weeks.
Right. One more question that we can take up is, what are the conversion rates of lumpectomy or mastectomy in patients undergoing surgery? And what measures do you take to enforce breast conserving surgery in patients planned for breast cancer surgeries?
The conversion rate is very low. In my experience, it is almost 4 to 5% only. Most important thing is margins of the tumor. What we do is all the patient where we do lumpectomy, we send it for frozen section examination. Frozen section means on table assessment of the margins, where I will know whether the margin is negative for the tumor cells or how much is the margin. If the margin is positive, same sitting, I do revision of that margin and remove 1 more centimeter. So I don't wait for the final report. When the patient is in anesthesia only, I send the lump for frozen section examination where my pathologist will study the tumor and tell whether the margins are adequate or not. The only reason for conversion of lumpectomy to mastectomy is if it is a multicentric tumor or more than two margins are positive, where we feel the recurrence chance is very high, we can offer mastectomy. But if on frozen section they tell margins are clear, then usually we don't go for mastectomy. That's why our conversion rate is very low.
Understood. That also makes sense now. Now, I'll just check if we have any more questions and then we can conclude today's
Sure.
session. So, as we conclude today's session, thank you so much, Dr. Goel, for sharing your deep insights and vision for the future of breast cancer surgery. And let me tell
Thank
you
you,
that
Hetvi.
your commitment,
Thank you, Hetvi. Thank you for being a wonderful host. It's my pleasure.
thank you so much, Doctor. And let me tell you that your commitment to innovation and patient care is truly inspiring.
Thank you.
Uh, and to our audience, we hope this discussion has been as enlightening for you as it has been for us. And thank you so much for being so engaged with us during the entire session. And Doctor, let me again thank you so much for sharing your insights, and it was an honor to have you with us today.
Thank you, Hetvi. My pleasure.
And we will see you in the next live session. Thank you so
Sure.
much.
Bye bye. Take care.
Bye. Take care.